Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse with a focus on hospice and palliative care. Those are two separate services. I'm also a certified end-of-life doula through the International Doula Life Movement. If you're new to this channel, welcome. Thank you for taking the time to visit. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Shouldn't we be prepared for what's to come? In my experience with hospice, 6 out of the 9 years of nursing, is those who wait to the last minute, everything's a rush. Everybody's trying to do the best that they can, but the outcomes are less guaranteed than if you plan for a good death. We're not talking suicide. We're not talking rushing headfirst to die. Just planning what is a good death for you. So the topic for today's video is looking at the community presentation that I did at the Madison County Public Library in Berea, Kentucky on Wednesday, September 3rd, 2025. That's the date of this filming. And with all intentions, this film is going to be published on YouTube on Friday, September 5th. And so I would like to share how did it go, lessons learned, what I'm planning to do different next time, because I strongly believe that if we are going to be operating in this field, we need to educate, have community presentations, and be involved in our community that we live for those we're hoping to serve. So before I go on to the topic of today's discussion, and to forewarn you, this is going to be a long video. This is the intro, and then I'm going to shift over to a slightly edited, mainly to remove me from walking to the camera to hit the record button and walking back at the end. But the presentation went slightly longer than an hour. But before I go over this, let me take a moment to ask, what are you grateful for? I believe there are 3 pillars for building resilience so that if we have crises and disappointments in life, we're not stuck to the floor for any longer than necessary. We don't despair. We don't circle the drain. What are you grateful for? I believe there are 3 pillars: faith in Christ Jesus, forgiveness, and gratitude. What are you grateful for? So what I'm grateful for is actually, I wasn't sure how many people would show up. I had the privilege and the honor to have a Zoom call with Casey March, and she did What is an End-of-Life Doula, the history of the movement, and how do you interact with one. She had over 75 people. She actually shared when I talked to her, the original room was set for maybe 10 to 20. They had so many people show up, they had to go to a different room. I wasn't sure how many would show up. So I booked the largest room in the library that could fit 42. Didn't know how many would show up. One person. We're going to talk about that as part of the lessons, but I'm grateful for that one person who showed up. I'm grateful for the lessons that I learned today that I'll be going over. I don't want to spoil the part of the message, but I learned a lot today in terms of scheduling these type of events. And I'm sure to be learning more, because I do plan to reach out to Sandy Adams of Just Love Coffee and Century 21, and Helen. I will work on her last name. I'm still working on it. But Helen, who owns Mama Bear Injury Lawyer, she's very helpful. But I'll be reaching out to different people. What could I have done differently? I think part of the issue, by the way, well, I'll wait on getting that. But I'm grateful for that. I'm grateful for Noel, who's my former professor from Harrisburg Area Community College, who he's now an infection control nurse up in PA. We're still very close friends as we can be given the distance. And he shared that he bought my hospice versus palliative care book. He's going to be doing a presentation at his nursing home, expecting 20 participants, talking about palliative care and hospice care. So I appreciate Noel. I appreciate every one of you that's buying and reading my books, and all of you who take the time to come and watch these videos. And with this video, let me move forward. I've been cataloging my journey of trying to do in-person doulaship in Madison County, Kentucky. I've been doing it remotely for about 2 years. I had a patient in India, a patient in England, I should say family members that I've been helping with. But I'm trying to build a community here in Madison County, Kentucky. So before I go into the actual presentation, some lessons learned. Number one, I could have, but didn't. I could have scheduled the day that I booked the room buffer time. I should have buffered a half hour before and at least a half hour after for the room. I booked from 10 to 11. When I went there for my care, I was there on the library on Sunday. I'm part of a caregiver support group where I do this as a volunteer to help out in the community. I checked in. Oh, come 15 minutes early to make sure that we can connect the audio visual equipment. And I found out today that sometimes it doesn't work with the Mac, which is what I have. So, okay, I showed up 9:15. That's more than 15 minutes. But I wanted to spread out, like I wanted to, didn't know if the tables needed to be rearranged. I wanted to have the table nearest the door. You know, here's a sign up sheet and here's the different handouts that I have for free and my brochure and my business card. I wanted to get that all set up. And I wanted to set up my camera. It's right now it's on my tripod at home, but I have this portable device that is so nifty. Just press a button and you have an instant mini tripod, and that's what I recorded with. But I only scheduled the room for an hour, and lo and behold, at the time of booking, the first hour before it was free. So nine to I could have went out to 1 was free, but I only booked 10 to 11. So here, when I got there, there was a group of people in that room. That's their right. And not only were they in that room, they actually went to 11, and had I not waved and said, I have the room booked, I mean, past 10, I have the room booked. And then it did take them about 5 minutes to clear out the room. So at 10:05, I'm getting in to do setup. Now I want to be extremely clear. This is on me, not them, because I ran over, by the way, too. This is not on them. This is on me. I learned I should book at least a half hour before so I'm not rushing people out of the room and I don't feel like a heel for telling, can you please exit us? I do have the room booked and they were apologetic, but I wasn't trying to be mean. And then I'd have time to set up the equipment and run some tests. And here I was actually, I want to say rushing, not to type like I'm tripping over myself, but when you get to the camera portion, you'll see lesson number 2. So most cameras have a balance setting where you could actually see lines on the LCD panel that'll tell you that it's balanced, it's straight. Oh my, lesson learned. I thought I had it, I did have it balanced for green, but I did not take into account that the projection screen was not balanced, and I should have just manually balanced a little bit more. So when you watch the video, it shouldn't be as bad that you're going to get vertigo, but it is at a slight angle, or maybe it's this way. I have trouble with my left and my right, but that was a lesson too. I'm still learning videography, and I did tell them that my background is um, breezy beige in the presentation, but it came out to be a faded green on the projection screen. But those are part of the lessons. But the other lesson is this. The other lesson, this I think is the biggest lesson of all. And I'm so grateful that I didn't rush out when nobody showed up at 10. Nobody showed up at 10:05. Nobody showed up at 10:15. And here I went with Eventbrite. One person registered on Eventbrite. Several people shared that they were going and or interested on the button, like I'm going to, if you're familiar with Facebook. And I did have one of the individuals reach out to me via Messenger Peter, I was so on planning to come. I hope you record this or take pictures. But a life event happened, and that matters more for them. And I'm glad that they took the time to tell me. But I told my wife I was going to give a solid half hour of waiting, maybe longer. I was debating, do I actually shoot the presentation and just do the video? But then I'm thinking if I was going to do that, if there was nobody there, I'd feel more comfortable and it would be higher presentation quality if I did the tutorial mode on the screen. At least you wouldn't get the weird angle that you're going to see when we move forward. But I waited, and I'm a pacer, so I got some awkward steps in. But one person came. It was the person who registered, and I don't know if they're still a paramedic, but paramedic. There wasn't as many questions, at least throughout, because of the medical background. But I did cover, and you'll hopefully hear in the presentation that you don't need a medical background. And we did have discussion on the end because she actually went to one of the webinars and got the same impression I did for a doula school that does the infomercial hard sale. And she actually attended the same one, maybe not the same date I did. But before I go too much further, I'm going to get into the presentation. This is a non-judgmental channel. If this is stuff that interests you, hospice discussions, holistic discussions, caregiver, patient, everything tied to how we live life but head towards death, please subscribe, hit the bell notification below, like the video. It really helps a small channel like mine. I don't know if I'll ever get monetized. That's not the purpose of this channel, but it does help in terms of moving it up in the chain for people to say, hey, this is a topic I'd like to know more about. Because what I'm finding about just this past week, there have been, I think, 10, 12 people sign up for the All About Death Doula Facebook group that Casey, a death doula, that she has her own school. I think it's called the Death Doula School. Short-term memories like this. You know, she said that they hit like how many people are part of this group. And people are commenting, I never knew there was such a thing as a death doula. I never knew that somebody could help prepare for this journey. I thought you had to wait until you were in hospice to know more. Wow. So the only way that this is going to make it up the YouTube algorithm is people liking and subscribing. So please do. And ask questions. I don't know all the answers, but I enjoy helping people. Thank you so much, and let's get to it. Okay. So if it's okay with you, I'll go through the whole presentation.
Yeah.
So today the topic is looking at what end-of-life doulas do. I happen to be one. But as I said, it's educational. So there's a Laura Hunter Smith is in Lexington with Bluegrass Death Doula. But what do we do? How do we work alongside healthcare teams? We don't compete with them. We collaborate with them. I'm going to jump ahead to the housekeeping before I go to the intro. But if you need to use the facilities, I'm pretty sure you know from being here, all questions are good questions. I don't know about you. I'm 62. I've not heard a silly or dumb question in my life. I'm not a fan of the word. I'm like, oh, this might be a stupid question. They're all good. In terms of about me, I'm Peter Abraham. I'm a second career registered nurse. Most of my nursing experience, 6 years, is in hospice and palliative care. I'm a certified end-of-life doula through the International Doula Life Movement. I'm a part-time instructor there, leading their continuing education development program, as well as development of a brand new course about how to have crucial end-of-life discussions for end-of-life professionals. I just love the educating people and helping people through difficult things. And I'm an avid book writer as well. I've published over 50 books, all healthcare genre topics. Next, if we go to the next. So for the learning objectives, by the end of this presentation, you'll know what is an end-of-life doula, how do we interact with the different, I call them circles of care as you go through your life journey, how we work with the different healthcare teams, how we support you at each stage, and when you might want to include an end-of-life doula. All right. Oh my. Okay. Go to the next. Sorry. Left my mouse at home.
Oh, I hate that.
It was like, I thought I had another portable mouse with me. So what is an end-of-life doula? In the simplest of terms, we are trained healthcare companions. Most are non-medical support. I happen to have my registered nursing license, even though we moved to Kentucky. I did get it endorsed by the Kentucky Board of Nursing. But most of them are in the field, are non-medical support personnel who are trained. We work with people who are healthy and well in terms of living wills, the advanced directives, through managing chronic illness, any type of serious healthcare diagnosis, and help them through decision-making processes that they make independently, but we help provide informed consent to help navigate end-of-life care. We're certified guides. I wish we lived in a world of no fine print. But you mentioned that you're a paramedic? Paramedic. So that's a level of certification that has a governing body involved. Mm-hmm. And the places that you go to, most are accredited, if not all. So when we talk about end-of-life doulas, for better or worse, it is currently an unregulated industry. So certification means I graduated from a school and there's no accredited school. So it's a catch-22. But as certified guides, we help families make those informed decisions to work through each stage. And some, like me, because I am a registered nurse, can provide additional support, such as reviewing medications for side effects, wound care, and so on and so forth. Let me hit the right place this time. There we go. What we don't do with fine print, those that don't have the medical background, no medical advice or treatment, none of us, even if we have a medical background, replace doctors or existing team members on the healthcare team. We don't make medical decisions for you. And those who don't have the training don't provide the physical care, like giving a bath or giving medications. But some, like me, I can do wound care, I can give medications, but we still don't replace the team members. And in terms of what I call the circles of care, I do have one item in the circle that is arguable, not a healthcare issue, but to me very dear to my heart. So you have healthy and well, advanced directives. You might know this with your background in paramedics, but less than 40% of Americans have a living will.
Oh, I know.
And that is beyond sad, because it leads to a lot of problems where, yeah, it's sad. I even know, like in my own family, my father-in-law had a living will, but no, and there was such a panic because he had and I don't say this to create controversy, but he had the Moderna booster, had a massive brain bleed unexpectedly, and the next thing you know, we're in the ER, bunch of monitors, alarms turned off, but no one remembered the living will. And it was like, I believe he wanted to die at home, but nothing that we had handy in writing that was notarized, well, properly witnessed and properly notarized, that we could direct the hospital staff, this is his wishes, mm-hmm. and they don't have to worry about getting into trouble from a lawsuit perspective, because if it's not in writing,
it didn't happen.
Correct, sadly. Then there's aging in place. That's what my wife and I hope to do when we move from Pennsylvania to Berea. You know, this is the last house we're going to live in. This is where we're hoping to retire to, although I don't know what retirement actually means. And this is where we hope to die. But then there's the, what if you're dealing with illness at home? What about community living? A lot of families, I know we went through this with my mother-in-law after my father-in-law passed away. She has Alzheimer's. Who's going to take care of her? A family decision was made. Let's look at assisted living. So there are times where the best laid plans, you still have to go, what else can we do for community living options? Hospital acute care, long-term care, rehab, memory care, and then palliative care versus hospice, which are two separate services. You probably know as a paramedic, but a lot of people when they hear it, they may not even know the word continuity of care. I went to nursing school in my 50s. 2013 were the prerequisites, 2014 clinicals, and from clinicals forward, including when I was at Harrisburg Hospital, it was like continuity of care. We have these electronic medical records, and therefore every doctor that's involved, every nurse that's involved, and so on, will know. They'll be up to speed and know what everybody else is doing. Broken healthcare system. I have cases in the same practice where one doctor comes in that's a different doctor than your regular, and why did they prescribe this medication? Or they may not even be aware of what was done. So one of the lessons I've learned the longer I've been an end-of-life doula, I've been doing about 2 years remotely. I'm hoping to provide help here in Madison County, and I did help one family connected to Berea just a few weeks ago. But if we're involved early enough in the decision-making process, we could be that contact person that provides continuity of care throughout the journey. And as we progress through those circles, our needs change. In terms of the circle, healthy and well, hopefully people are getting regular checkups with their doctor. I am guilty of only going when I have illness, but staying active, hopefully eating well, planning for the future, which should involve advanced directives. One of the lessons I learned in this field is like looking at the state of Kentucky. The advanced directives is 8 pages, and it's rather basic. It does give you a lot of places to put in your wishes, but a lot of people don't know that you could do an addendum for dementia directives. You could do an addendum for mental health directives, such as, are you okay with electroconvulsive therapy? Maybe there's certain antipsychotics that you don't want as part of your journey. And you can also give guidance as to what you want done in a certain order, like put me in seclusion if I'm having behavioral issues before you start giving me medications. There's also a directive for voluntarily stopping eating and drinking for those states where medical aid in dying is not yet legal. And there's also that power of attorney, both medical and financial as well. Then we have aging in place. There's home health agencies, physical therapy at home. Maybe there's meal delivery. I really appreciate Berea and Madison County at large at how well they support one another on the food issue. Managing illness at home, you're working with your family doctor, making emergency room visits when needed, taking medications, following treatment plans. You have community living, retirement communities. I'm still learning about Berea Village and how they help people in the community. Arcadian Cove, I was just at last Friday. I'm losing track of days. But you have that. I believe the Terrace is long-term care.
I don't know.
That's,
We've only been here for 6 years.
It's going to be the first year come November. Hospital acute care in terms of serious illness, surgery, treatments, recovery, rehab. Then we have long-term care, rehab, memory care in case of dementia, which is a bucket term because there's 13 known types. Alzheimer's among the most common. Palliative care, where they can get comfort care and curative treatments. I'm learning about the different areas of palliative care in Kentucky. Matthew West, not the singer, there's a registered triage nurse at UK Health that was really helpful in terms of a massive spreadsheet of here's all the palliative care service providers in Kentucky and what counties and what do they deliver and do they have any limitations. Genuine palliative care should be symptom burden driven, not involving a diagnosis or a prognosis, but there are certain palliative care providers that do both. Like UK Health is only cancer and then life limiting. And so in a way, it's not as authentic as it could be, but that's a hope down the road. Then there's hospice care where there is a prognosis of 6 months or less, not using the traditional calendar system, because people will look at Jimmy Carter, who was on for 2 years, and other people, like the average length of stay is 18 to 21 days. And I read a case just this morning that their loved one was on for 12 hours, yet the benefit is 6 months. But the support is on the whole family. Peace and dignity is the hope. Now, in terms of how do we fit into the different circles of care, we're hoping to guide the different conversations. We mentioned when you came in, a lot of people don't like talking about death and dying. And I'll share a story in a moment about a family that I talked to just this past Saturday from Berea. You know, we help walk through what-if situations, which was part of the discussion on Saturday, talking about the difficult topics, explaining things in simple terms, but like, what does a good death look like to you? And I know, as like, you have a family, and when we get so excited when somebody's going to come into the family, whether it's a birth or, like, my wife and I adopted special needs teenagers, they're adults now, but like, what room are they going to be in, and what's their favorite color, and can we afford helping them with college, and to what degree, or VOTEC, and to what degree. And so going through all this planning, because we know that planning will help. Even if all goes to Hades, they're better off. But when it comes to death and dying, we'll get to it. And then sadly, it's there, and then we're rushing, and it's not as good as we can hope to be. But Saturday, what does a good death mean? And one of we had a family discussion, and the spouse said, "I want to die in the hospital. I don't want to be a burden to my family." And that is so common to hear. I don't want to be a burden to my family. But when we went over the reality checks, I worked in the hospital setting. We're not trained on how to keep somebody comfortable. We're there to rescue those who could be rescued, to maintain those who could be maintained, where somebody's comfort's the last thought on our mind. And on top of that, and this was my fear when I was working in Harrisburg Hospital, and this happens nationwide, so I'm not picking on Harrisburg Hospital, but I would have fellow staff members, when the call bells would go off, "Oh, that's so-and-so wanting their pain medication, they're drug seeking," and they come up with all these labels, and it's like they don't remember the human factor, that they're in pain. Everybody's different as to what level somebody can tolerate. I was just having a discussion this morning. I help out a lot of different social media groups, where somebody was asking about a loved one who has a pressure injury. They don't seem like they're in pain, but are they having pain? And I'm going over, like, wound care often brings discomfort. So we help walk through some reality checking. And as I went over that, like, how we're not trained in the hospital setting for comfort, and even like with the case of my father-in-law, they didn't have any comfort meds in place. They didn't think to deactivate the ICD. That could be shocking him if he went into an arrhythmia that would cause the ICD to go off. So I'm there and I'm saying, please get these orders in place. And then when they did get them in place, palliative care doctor came in, got the orders, found out they were only for one time. I don't know if that was to appease us, but it was like, I went to the nurse, that's wrong, yes, but they don't have the training unless you have somebody advocating for them. So we're part of that. Managing illness, PCP, urgent care, emergency room visits. We help prepare the families, like, here's what questions to ask. And to give you an example of that, I had a colleague, a fellow end-of-life doula, reach out this week. They have one of their clients, an 83-year-old who has AFib, the irregular heartbeat, was going in, and they don't know if they qualify for surgery. Ablation was out of the picture, but they were looking at other options, what questions to ask, so we'll work through that. But in this particular case, I try to encourage a lot of everyone at large. A lot of times it's not the medical questions. I shared, what does she want out of quality of life? What's on her bucket list for the next 2 years? because you want to think manageable buckets, and look at what do you really want to accomplish in 2 years for quality of life. Then when you're at the doctor's visit and they're going over the procedure, say, if I get this procedure, you put me on this medication, how does this impact my goals over the next 2 years? And you could have specific items to ask for. And so that could be really helpful. So we work through just the what ifs, and here's how to better prepare. Then we have hospital acute care, where we're advocating for the different options, providing a calming presence during procedures. You know, sometimes like coming into the hospital and say, can you just share, I don't understand. I asked them to speak English, but they keep going over my head. And then on top of that, I'm finding more and more, even with hospice, that if somebody's dealing with anxiety, and rather than looking at what the prognosis is today, they're dealing with anxiety, let's jump to lorazepam, which is a very good medication for anxiety. But if the person has dementia, for example, and their prognosis is, let's say, 3 to 6 months as of the moment of the discussion, there's better options, because lorazepam could actually be harmful in that case. So that's where, you know, we might be able to come in and say, here, have you thought of this or that? At the end of the day, everyone else makes their own decisions. We're not trying to interfere with the autonomy, but we're trying to give them, here's some help. Or maybe they're aging in place, they're having home health come in, and it's overwhelming. And the older I get, I'm learning a lot of people, for whatever reason, they don't advocate for themselves.
Oh, I know. My parents were, I would say, well, did you ask this? Well, no. I'm like,
Well, they're expecting the other person to tell them. Like I'm flustered at times. Like, I love that people ask questions, but on social media there was a family asking, you know, they were giving, this is the description of what their loved one going to, what does it mean? And I answered them, but I said, did you ask your hospice nurse? Because they are the best source, because they're, like, I'm not their hospice nurse. I'm not there, I don't have, like HIPAA, I don't have access to everything. And they said, no, they thought their hospice was going to tell them. And I said, in the best world, like I would, because when I was up in PA as a hospice nurse, I would, but not everybody's like that. When I check with my colleagues, a lot of them say, well, I'm waiting for the family to ask. Don't educate, just.
My mom would be like, there was a doctor, and I kept saying, you need to find a new doctor. You really need to find a new doctor. And she just, you know, I think they think, well, that they don't have any business questioning.
Yeah, and that's too, is like the doctors are trained. Like my in-laws were like that. If the doctor said, the doctor's 100% correct. But to just give you an example with that, and it's not that they're wrong, but I had a case, and this to me is a testimony of why hospice sooner than later. Granted, in this case, I had a 104-year-old come on to hospice. It was, I guess, towards the end of April, beginning, maybe mid-May at the latest of last year. Daughters, 2 weeks to live. The admitting nurse, I was the case manager, admitting nurse was 2 weeks to live. Her doctor, that happened to be our medical director, 2 weeks to live. And I come in, and initially, 2 weeks to live. They're still giving her 3 blood pressure medications. One was Imdur. I don't remember the other 2. And her anticoagulant. I think it might have been Xarelto, not 100% sure. And I come in, and just things were not looking right. I'm seeing symptoms of dying, but there were other symptoms that just didn't make sense. So I go to the daughter, do I got your permission to get her off the blood pressure meds and anything else that I think might be causing an issue? Go ahead. And a good hospice team will always ask the family. Hospice does not take charge of medication decisions. Daughter said, go ahead. But for me, when I'm going to the doctor, who agreed with 2 weeks, it was pulling teeth. 1 med. And then when we got to the Imdur, is she having chest pain? Well, she's in and out of consciousness. I can't ask. And on top of that, her memories, there's a level of dementia.
Yeah.
Is there a history of chest pain? So I'm giving her, several years ago, she had chest pain. So eventually got her off of all 3 medications and the blood and anticoagulant. Within a few days, she's getting out of bed. This is a person who's in and out of consciousness, constantly falling out of bed because we thought terminal restlessness, but she's actually getting out of bed, getting dressed except for her bra, getting her walker, and appropriately, you know, people use a walker and they're using it backwards.
Yes.
They're walking forward, but they have it backwards. She's using it correctly to go out to the dining room, eating a full meal, regular texture, and being able to have a full conversation. Granted, a lot of it was fanciful,
Yeah.
but it was contextually for her imagination. Granted, I'm not in her head, but it was intelligible words. You can't say on the fast scale, she wasn't a 7A.
Yeah.
She was definitely conversational. So she was a 6E at the worst. And I'm telling our team, get her off of hospice.
Yeah.
But that was a case where the doctor prescribed all the meds at when the time was right, several years back. But people don't go and ask these questions like, are these meds still needed?
Mm-hmm.
You know,
people's weight changed. Everything changes.
yes, and without asking questions and having this, they're on a pedestal
Yes.
thought process. But when we're involved, and we're not miracle workers, and when I bring up God, I'm not trying to preach, but God's God.
Mm-hmm.
And so, but when we're involved, a lot of times, well, they don't listen to family members, but you bring an independent source, maybe they'll listen. Then you have community long-term care, supporting the decision-making process. I'm still learning Kentucky, but I have a feeling that this is going to be similar to in Pennsylvania, nationwide. But making a decision, do I go to a personal care home, do I go to assisted living or long-term care, is hard. And as they're going to different places will make promises that I do believe they intend to keep, but not everybody's always asking the right questions. Mm-hmm. Like if a person has Parkinson's but no dementia, they're at risk for getting Parkinson's dementia. And if they go to assisted living that's not properly equipped for dementia, they may end up getting told they may have to leave, mm-hmm. even though at the time they were told, you could stay here until you pass. Yeah. And so we can help work through, here's what to ask, or maybe they make that move and now they're feeling lonely or unsupported. We could be a part of that team that comes visit, checks in and advocates for them. If they need palliative care, we're working alongside the team, and as the palliative care doctors are focusing on physical comfort, we're working through like the fear of what's next and what are the hopes, and working through that. And just trying to be mindful in case there's another party coming in. When it gets to hospice, we're transporting them, if they were on palliative care, to now they're looking at comfort care only, working through the different milestones. This is similar where the hospice nurse is managing the medical decisions. We're looking at the additional training. So I may have mentioned earlier that I recently helped there was a Berean family that said their extended family out in Ohio is going through a hard time. Husband and wife, they're both veterans, they served their country. The husband has stage 4 metastatic cancer that spread throughout the body. They're with the VA. Wife's a retired nurse, but this is very difficult for them. They're not sure what to do. I said, here's my name and number, and call me. And what I'm sharing is some of this is after the fact. Mm-hmm. So on a Wednesday, that portion's after the fact. They're at the oncologist office. They're getting scheduled to have hospice admitted. They didn't know at all about palliative care. Mm-hmm. They didn't know that was an option as part of their journey. Later on, when I talked to the wife, that would have been so helpful for them for years to be palliative care, but they didn't know about that. But as they're getting ready to get scheduled for that hospice admission, the oncologist sticks his head into the room and says, there might be one more clinical trial we can talk about. Let's schedule a call for Monday. So this is Wednesday, Monday of the following week. And so the person who's scheduling the hospice admission says, you know what? We're going to wait on the scheduling this. why don't you call us back after you know what you're doing with the clinical trial? It's not that they were wrong when we talk about right versus wrong, but it was very uncompassionate. And Medicare regulations allowed for the admission to take place. They could have been admitted that day and either revoked or been discharged the day before or hours before actual treatment. Medicare A is what pays for hospice. And so they would just have to manage how's billing happen for the trial, whether they had to discharge the day before or the day of. But here, the wife ended up calling in tears Friday and could barely speak because they're just emotional, like how long does this confusion last? And he's in a lot of pain, but I only have tablets. What happens if he can't swallow anymore? And so here, I had an hour-long phone call. I'm not looking at the time. I only know from the, when your phone's keeping the track when you hang up. And I spent a good amount of time just validating feelings, calming. We'll work through this. And I said, what changed since Wednesday? She mentioned the confusion. And there was a lot of that. But what's happening overnight? Well, overnight, his respirations are in the 30s. Now, you know a paramedic, but normal respirations 12 to 20. 30s is extremely high. She's a retired nurse, so she has the pulse ox. I'm not a fan of vital signs at end of life, but people get them. He's in the low 80 percentile, so normal's 91 to 100. Yeah, non-COPD, if they have COPD, 87 to 89, but this was very low. And so I said, at the end of the day, you make your own decisions, but here's my recommendations. I believe he's transitioning, and I went over what transitioning means. Dying is 2 stages, transitioning and actively dying. I believe he's transitioning. Based on the speed of decline, I don't believe he has much time with us. Please, this is your decision, but I recommend calling the hospice provider, asking for an admission that day. If they bring up the clinical trial, bring up the changes from Wednesday to Friday, and I gave her a bullet point script. I said, what I'm finding out nationwide, a lot of hospice providers are making a decision not to give what's called the comfort kit on the day of admission or even the day after. Those are the liquid morphine, the liquid lorazepam. They don't euthanize, but they're there because crisis can happen. And I've been as a hospice nurse, I've walked in and the meds aren't in place. Or the doctors made all the phone calls and I called the pharmacy, they never got the fax never went through and nobody double checked. And I'm walking in and the family's looking at me. Hospice nurses here as if a miracle is going to happen, and I believe.
Don't have
I believe I'm a good hospice nurse. I believe in miracles, but God's not a vending machine, and I can't.
And if the medicine's not there, you cannot help with the pain.
Correct. All I can do, and if you ever have a chance to, if you've ever heard of Naomi Fell validation therapy, she's an amazing individual. She passed away late 2023, but she developed a set of techniques. It involves your tone of voice, how you word things in terms of validating their feelings and their experiences. You're not arguing with them. You're not correcting them. You don't have to lie. I don't believe in therapeutic lying, but there's a way to talk and a way to share things that I do have a case where I did use validation therapy with no meds, and I was praying fervently. So I honestly don't know, was it the prayer or the validation therapy over 45 minutes where I was able to calm somebody down that was in distress, because emotional distress is pain. And so the companies are doing that where they don't have the meds in place. So I said, when you call the provider, make sure they deliver the comfort meds. And while oxygen is not always needed at end of life, because of the high 30s and the low 80s, ask for the concentrator. So I checked in with her a few days later, and he's comfortable. But then there's questions of, this is what he's going through. In the hospice nurse who was coming on a regular basis didn't go over terminal restlessness. Because a lot of staff, I'm learning, you got to be in and out, like 30 to 45 minute visits. So they're spending maybe 10 to 15 minutes on the assessment, refilling the medications. But in this particular case, they didn't go over oral care. They didn't order the mouth swab, so I'm saying we're doing a reminder because we're supporting the team.
Yeah.
We're not throwing them under the bus.
No, no.
We're saying, here's what you need to call and ask for oral swabs. And the nurse did get them. She actually went back to the office to get the swabs. But here's how to do the oral care. So we're filling in the gaps that are unintentionally made.
I feel that a lot of hospice nurses, there's not enough hospice nurses.
No, there aren't. And I love this space, but part of the reason I'm walking this journey is when I got to Kentucky, and we moved here November 13th. I worked with the Kentucky Board of Nursing, got my license endorsed December 13th. And my wife is like, you're going to get a job before her. I'm 62, I'm looking for part-time. And all the places are looking, if you're part-time, they want you for 12-hour shifts. And even though Hospice Care Plus has a good reputation in the area, 12-hour shift, and I talked to Chastity, who's the director of their inpatient unit, she admitted sometimes it's actually a 13 or 14-hour shift just because of documentation and when your partner might have been caught up in traffic and explode. And so I feel if I can't help out that way, maybe I can help out this way. But that's where we can help fill in the gaps. Now, this person did pass away in less than 2 weeks, but we were able to provide those educational milestones and help with that. As we come, we're working towards the landing zone. This is just showing the whole timeline that we can be involved in, from 18 and healthy, looking at living wills, even to like how do like, oh, I have the funeral prepaid, but like, did you work out your eulogy or obituary? Do you need help with that? What about legacies that can last for generations? Education resources. Get a life limiting. Life limiting could just be diabetes. Changes where, oh, I have to do this and that. End of life planning throughout, advocacy. You have accelerating decline. They're fading away, slipping away. Hopefully by then, if not advanced directives, let's getting them in place. Advocacy, education, vigil. I've seen so often in hospice, at least in PA, a lot of families, they don't realize hospice at home, they're not there 24/7. And when it comes time for vigil, even though I would educate families like that are hovering over their loved one when they're in a comatose-like state, have you left the room? Because they'll be asking, why are they still here? Sometimes they need to be alone to pass away. But even so, they want that coverage. Like, can somebody be there with them? And I remember the different agencies I worked for, they're reaching out to, can we get volunteers we need this time slot filled and that time slot filled. And it was literally a roll the dice for filling the gamut, where if we're involved early enough, we could be working with different parties, like creating that schedule long before they're in that state. And that way it's better work through. Then after they're passed, grief counseling. I'm taking a certified grief coaching course, so by December 15th I'll be a certified grief coach. But we can help with that, practical support, advocacy, education, finishing up any legacy work, working through resources and referrals. Working together again, we add to the team, we don't replace anyone on the team. We're the calm voice when things are chaotic. We're the bridge between your heart and the medical care team. And we're the supporter for the whole family. When to include us, anytime, sooner is better than later. The more I work in this, and I believe you feel the same way, Tammy, with that living will is so important, even if they do it themselves. And the one thing I would add, and just to share with the people that you talk to, most of the time you do not need an attorney. It's only if the family has complicated disputes that you want to have an attorney involved. What I do tell families, you want to make sure that it's done in blue ink. And even though the Kentucky form on the last page will say either two witnesses or notarized, do both.
Yes.
And the Berea Library here, both in Berea and in Richmond, the Madison County Library does free notaries, and they can provide the witnesses the majority of the time. If you have it blue ink, witnessed, and notarized, it's legal. And that's so important. But when families...
Is that information in here?
No, sorry, no.
Okay.
Or actually, it might be in the one handout. I believe it is the one that's
quick
four.
reference?
No, the 4-page, the one in your right
this
hand.
one?
Yes,
Okay.
I believe it is. I'd have to double.
Yeah, I'll look, not right now, but I'll check.
And feel free to reach out. I'm weird from many perspectives. Hopefully it's weird in a good way. I'm probably the worst salesperson that ever exists because I do a lot for free. And to me, because I believe we're here to serve and to help. So I don't mind, like, what did you share with me with this? It's like, oh, let me put you on the clock. I'd rather, to me, it's one person helping out another person. If it gets to be where it's like this is turning into consulting, that's a completely different story. But yeah, we're part of that picture. What I end up seeing the longer that I'm in the end of life field is that when a trained individual is involved, families feel more prepared, more supportive, and it's a beautiful, rewarding position. So we are at the end, and thankfully we did good.
Yeah.
But we're there to support you and your family. What I try to share in terms of jumping to the remember this is you don't have to face this journey alone. And that's my long-term goal. Compassion Crossing LLC, even though I mentioned I do a lot for free, it's for profit. So like I would charge, for a living will, for example, for a complete and thorough one. Not for odd and end questions, by the way.
Yeah.
But if like you're working through, like, let's work through the dementia directives and all the other directives, and did you miss this and miss that? But here, my long-term goal, or I should say like a 3 to 5 year goal, is I'd like to have a nonprofit, because especially in Kentucky, whether it's Appalachians or elsewhere, poverty is left and right. And I don't want to have anybody turned away.
Yeah.
Like if I'm dealing with a family where, can you do a vigil? We don't have any money. I'm going to see what could I do?
Yeah.
Because like right now I am 62. I'm blessed I'm an avid writer. I mentioned in the book, so I get book royalties. I'm an avid writer. My wife's working, and if I could do something to help somebody in need,
You will. Yeah. I know. I totally get that. Totally get that. No, I worked long before I was a paramedic or anything. Back when my husband and I were first married, and I got my CNA. So I was a CNA for many years, and then I did home health. I did all that in Missouri, and then he went to Korea for a year. When he came back, we moved to Nebraska. There I worked at a private nursing home. Well, private. It was home.
Do you want this on camera?
Oh, I don't care.
Okay.
Masonic home. It was a Masonic home.
Okay.
But I remember, even in Missouri, the nursing home I worked at and stuff, I felt so bad for the residents that, or the patients, that, you knew it was close, and they had no family. And I would try to stay in there with them as long as I could, but, I had other residents I had to take care of and stuff, but I hated that. I just hated it. And that was back in the early 90s.
It's hard, and I
Or
think
late
it's,
80s, I should say.
and in some cases, gotten like COVID did a number on us from a wide variety of perspectives. And I think the hardest hit was the humanity of it all.
Yeah. But because you couldn't be around anyone.
Right, because of rules you found out later that were made up.
Oh, my husband tells me all the time.
Yeah, they made up the 6-foot rule.
Yeah.
But I still, like, not even getting into like the wave one and the different waves,
Mm-hmm.
but like several years after COVID, like this is in, I think it was late 23, I think it was in late 23, going to long-term rehab as a hospice nurse, you know, in case management. And I had a new case, and I'm talking to the son. When did you last visit mom?
Mm-hmm.
Well, I haven't been there in 3 years, literally 3 years. And I do my very best to be non-judgmental, and sometimes that's hard because it's like, how do you balance the reality checks? Because I do believe we need to do reality checks. And I said, can you tell me more? Because I felt that was the safest way to ask about it without whacking somebody on the head. And he said, well, with COVID, and you never know what you're going to catch.
Yeah.
And I said, well, there's no COVID in the building. And I was being honest. There was no COVID in the building.
Mm-hmm.
There's not a single case of COVID in the building. And I'm here. And others workers are here. And after some very gentle prodding, it did take several calls, he ended up coming and visiting. And after I talked to him, he said, Peter, I'm so glad that you encouraged me to visit. It wasn't as bad as I thought. But when it was that whole idea that if you go out in public, if you get this, it's a death sentence. And it was so, I worked in a very short, like I took a break from hospice. I worked in a very short staffed nursing home. Our very first resident to get COVID was a 102-year-old gentleman who had dementia, who was on lung disease already, on oxygen, could not follow commands, and he recovered in 16 days.
That's awesome.
Well, it's its own story, but our director went through 5 directors of nursing in 7 months, but the very first one said, the CDC is saying check the temperature only. That works if you're younger. Geriatrics, it's the very last sign before either they're going to die or they're going to get better. And she said, we're going to do physicals, full assessments every shift, not just day shift. If there's any change in lung sounds, we're going to suspect like we're going to have green, yellow, red zones. We're going to suspect positive. We're going to move them to yellow. We're going to test them if there was a 5-point change in their oxygenation. So you had a set of scientific guidelines to go through. And because they did that with early detection and early treatment, we're not talking anything controversial, but we're talking artificial hydration if it was needed. And working with the kitchen was the hardest part. You don't feed hoagies to somebody who is lethargic.
No. No, it's not going to end well.
No. Can you have like soups and finger foods that are very, like when we talk finger foods, we're not talking the massive handful.
Yeah, not the big sandwich. We're talking just like crackers. And
small stuff. So that the biggest education was the kitchen. But because they did early detection, early separation and isolation and treatment, we had 99% recover. And I'm a geek. So I love talk. I'm an introvert, but I don't mind talking to single person, like small groups.
No, I understand that.
And so I'm talking to different people. I talked to a director of nursing in Maryland. They had 104-year-old. And they had a 100% recovery rate for their entire base. And most of York County, Pennsylvania had 100%. One nursing home followed the CDC guidelines to the letter, and only the CDC guidelines had a 50% death rate.
Oh, gosh.
That's its own story. But did you have any questions on?
No,
And
it's very interesting. Yeah, I've actually, before we moved here, one of the guys I worked with, he worked part-time, but his wife was interested in this, and that's how I found out about
Mm.
it. I had never heard of it before.
Well, if she is, have her reach.
She's in Illinois, and I don't
That's
even, yeah.
the reason that I mention this is I've been working at connecting with a variety of people, and this is not to sell them,
Yeah.
because even though like I'm a part-time instructor, I don't own, like I'm not management in the school, so to speak, but I can give them guidance and direction, because the caveat is it's unregulated,
Yeah.
and that's both a blessing and a curse. The blessing is hospice is highly regulated, and what we're seeing, because of like hospice when it first came to America was nonprofit. And while there are bad nonprofits, because nonprofits are tax status, not a guarantee that they're going to do anything right, but most of the time the nonprofits had the right heart.
Yes.
And it was flourishing and doing well. But the big conglomerate saw that it's flourishing and thought if we come in and we come up with the policies, procedures, rules, we can make a lot of money, which they are, for better. Well, I'm not saying making money is wrong, but to me, healthcare, I'm fiscally conservative, but healthcare is where I'm very liberal from the perspective of access and not necessarily free. That has its own caveats, but access to me is extremely important, and the very basics.
Yeah.
And here, I still remember the one company I worked for, I was never written up for it, but I would get chastised, Peter, you're taking too long with your patients. Like I had mainly home patients.
Yeah.
And the software would tell your drive time, your in-home, because I had GPS, your drive time, your in-home time, and your documentation time. Now I did my documentation in the visit except for admissions, but my average visit time for a home patient was around an hour and 15 minutes, an hour and a half. No, it's not. But like I had a case, I had a patient in Glen Rock, Pennsylvania, that they're near the Maryland border. I was there for close to 4 hours because they were they died the next day, but I didn't know if they were going to die in my present. And it was an hour drive to home. They were my last patient. And the policy of the agency is if they were to die and they were to call the agency, and even if it was 1 minute before 5, they would be, Peter, you have to turn around and go and pronounce. It didn't matter that my shift ended at 5. You're still on duty until 5.
Yep.
And so I wanted to be there to support the family and save myself if I had to come back. But I would get regular flack for that. I had a drug addict for a patient that was a home patient. My average visit for them was 2 hours because I'd walk in. There were cases that were completely unresponsive. The wife had MS. It was an odd living condition because the daughter had a younger child, and there was somebody else in the home that we had no clue as to what the relationships were. And we weren't sure, was this person overdosing on our meds or on street products? And then when I'd find them non-responsive, everybody was around. Is he going to come out of this? What are we going to do about it? And I found this out. Kentucky's like PA, the hospice nurses, at least this area of Kentucky, we don't carry Narcan. So we don't carry that. And so what do you do? So I am coming the next day if he's non-responsive, but my visits were 2 hours, some longer. So I had a nurse come one of the days I couldn't. And because the software documented the time, she was in and out in 18 minutes. I was flabbergasted. Like there were so many narcotics in the home, we would count the narcotics. It would take me, I had a pill counter, like you can get them on Amazon. So I'm counting that, the liquids and everything else. And I would do, this is what he had last visit. This is what he has this visit. This is the difference between the two. And according to medical records, this is what should have. So there are actually 4 columns, not 3. Because what good is counting and knowing the difference if you don't know what should have been used?
Yes.
And that was what I was finding out is he actually was overdosing on street products, at least suspected. I wasn't, that's the part when somebody's on the floor, did they fall or did they place themselves there?
Yes.
So, but 18 minutes. And now she did count. She had a before and after, but no other, like what should have been used. And then take 18 minutes. And she would actually brag that the longest visit she had over the years in hospice was 45 minutes because a wife made her. And I'm thinking to myself, we don't bat, like, I'm not trying to hit somebody over the head,
Yeah.
but inside my head, I'm going like, you're bragging about being uncompassionate?
Yes. Then this isn't your type of.
Yeah, but her skill was through the roof.
Mm-hmm.
Like we had a case that would have been my patient had they got to me.
Mm-hmm.
But as a paramedic, you probably know what wound dehiscence is. Where they did an operation, they surgically they did everything together,
Mm-hmm.
and it comes apart,
Yes.
dehisced. Well, they had a wound at dehisced, and that was mainly the only reason why they were they went to a hospice house.
Mm-hmm.
And so this person came in, their clinical skills were so good that they knew that number one, they shouldn't have been discharged from the hospital with a dehisced wound. They violated so many different rules and regulations. So she got on the phone that checked with the POA. Is it okay for them to do this? Because if they fix this, he may not be dying.
Mm-hmm.
So clinical skills were through the roof. Unbelievable, amazing nurse from that perspective, but not compassionate in terms of the education and the time.
Mm-hmm.
But I would get flack from my management team. You need to be like that nurse.
No, you don't.
No, it's like, I'm going to be me.
She clinically was a very good nurse.
Mhm.
She should look elsewhere.
Right.
Yeah,
Not that field, because to me, for this field, is I've had cases where I'm only there 45 minutes, but all needs met.
Yeah.
But if there are needs, no one's there. But if there were needs, I'm going to be there. There's a catch-22. Like I still remember I cut my teeth on very rare and hard cancers. This is 2018. I still remember my one home patient where I walk in and they're barely conscious, and they're saying, I think they overdosed on their medications. Not the comfort kit. It was not that would have made a lot of difference. And they're handing me their flip phone call, and they gave me a first name to call, and then they pass out. They never woke up. They didn't die that day. And I'm like hoping I can get the first person on the phone. It happened to be the first person with that first name, because you can give me the last.
No.
There's a lot of people with that first name on their phone. I hope it's this. But then I'm going, how long could I stay? Because I had other people to see, and I'm calling the management team, I may not be able to see all these people. I'll stay. But you get to the point where you eventually have to go.
Yeah.
So there is a balancing act. But that's the part where, because we're an unregulated industry, no one's telling me how long to stay to come and go.
Yeah.
And there's people that are in our industry that are fighting to get regulated so insurance would pay. Because one of the common questions is, how are we paid?
Yeah.
And it's private pay.
Mm-hmm.
That's part of why I want to do nonprofit, so I could get raise funds so I don't have to worry about where money's coming from. And that saves, I don't have to be a salesperson, especially if donations are coming in for that. And I am sliding scale, by the way. But here, if it gets regulated and you have insurance coming in, well, you're only allowed to spend an hour, and this is what the going rate is for that time. But because it's unregulated, the schools that are out there they're literally cropping up, because people are saying, I can make money teaching people about being an end-of-life doula. And so there are workshops that'll pop. Oh, this is a weekend workshop for $3,000. Before I went through the International Doula Life Movement, I'm thinking, because I'm a hospice nurse, I could actually, I wrote books, can't I just certify myself? Mm-hmm. And technically I could, but I wanted to go and do it the right way by going to an independent school. Mm-hmm. And so I'm doing homework, and it's like, oh my word, all of these different choices out there, and some of them are pre-recorded lectures. Mm-hmm. And where I went, the school's based in San Antonio, Texas, so while they have on-site, and they've been working with different states, they're set up with Quinlan Hospice in New Jersey, where you could actually go on-site and have patients to actually work with. That's the plus for on-site. But for me, I went with live Google Meet. So so you're on a camera and it's interactive.
Mm-hmm.
World of difference. So if you still have communication with your friend, I think you said Illinois, have them reach out.
Okay.
You know, I could point them. There's the National End of Life Alliance. That's the only independent source for information.
Okay. Perfect. Well, thank you. This has been very informative.
You're very welcome. I'm glad you came.
I am too. I am too. It's a lot to think about.
It is.
Also, so you went to, where did you get your training?
For the Doulas, through the International Doula Life Movement. That may not be in any of the flyers. International
How is
Doula.
it expensive?
I don't believe so. I'll let you write down and then I'll go over
Doula.
Life Movement. I keep telling, I'm becoming friends with the owner. She picks my brain for the nursing questions.
Oh, okay. That makes sense.
But and she's been in the field for 23 years. The doula field has been decades.
Yeah.
But to answer your question on their entry level, they have an entry level course. That's all you need for certification.
Oh, okay.
That's $850.
Oh, that's not bad.
They do have scholarships available for those that can't afford the $850. The hard part for saying like what's expensive to some versus another, like for some people you might say, you know, oh, it's $850, and they're thinking.
Yeah.
But to give you an example, like what infuriated me in the beginning when I'm looking at schools, there's a well-known, and I'm not even going to name it. Please don't be mad, because I don't want to be like picking on something. I think people need to come to their own decisions, and it's better to not give biases for certain things. But here it is found. The school is founded by a I don't know if she's still practicing, but a former hospice and palliative care nurse. Very charismatic, great speaker, intelligent, compassionate, hits all the buttons, clinically sound, but promotes everything through an infomercial lens.
Yes, I think I've seen that one.
And so I went through a 4-hour webinar, 4 hours. The first 3 hours was wonderful information. I'm like soaking it all up.
Yeah.
And it's a Zoom call. And I'm chatting with different people. This is so great. I thought it was great. The last hour was hard sales. The last hour was, this course normally goes for $7,997.
I know exactly what you're talking about.
But if you sign up over the next several hours, it's going to be $2,997.
I know exactly which one you're talking about.
And then they're going, and all of the stuff that they're including for free. Now the hard part when you talk included for free, if it's something you sold, if somebody bought it, you know the value of it because somebody paid for it. Like my books, I have an end-of-life doula care planning book that's $38.95.
Yeah.
And if somebody buys it, they've confirmed it's worth, at least to one person and to every buyer, it's worth that. But if it's never sold, and in all honesty, like some of my books that I've written, they're on Amazon, some have 0 sales. For over a year, 0 sales. I'm still glad I wrote them.
Yeah.
But guess what? Technically, they're 0 value.
Yeah.
Now, I'm not touching the price for now, but they're 0 value. So if I went in, granted, it's not that I'd be lying if I gave them the list price on Amazon. At least I'd have that they're at least on the market. But if you have something that you've created that is on no marketplace and you say it's this value, it's up here.
Yeah.
That's not the real value.
Yeah, exactly.
But when I heard that, and then on top of that, people in the chat were going, I'm called to this, but I'd have to mortgage my home. And there were people that were literally, because it was a Zoom call, so you know how you have the different windows. There were people that were crying because they felt called for this and they can't afford $2,997. So I'm in the chat typing away. I'm not dissing them because I believe in being non-judgmental, and that's their price. It's their price.
Yeah.
But I'm saying, you know what? An alternative, if you need to be certified, you join the National End of Life Doula Alliance, NEDA, N-E-D-A. You join NEDA for $50, N-E-D-A, the National End of Life Doula Alliance. You
Okay.
join them for $50. You wait 72 hours. Now they'll tell you on their page, give them 48 hours. I tell people 72.
Yeah.
Wait until you're listed in the membership directory. Verify that you're listed. Then you pay them $115 to take their proficiency badge test. So now you're out of pocket $165.
Yeah.
Now you're certified. Now, you didn't go through school. They have a study guide.
Yeah.
And it's not, I do believe that the person going that route should educate themselves, video books. Like I have a book, I have one combined book, like How to Become a Death Doula is one of my $38.95 books. And then I have 2 volumes, like if somebody wants a 6x9, it's $20.95 for foundations and practice. Another one on business growth. But whether buy books, they don't have to be mine. There's a lot of free stuff on the internet.
Yeah.
And this is where, like, I'm weird. I can point to different free resources. My website that's listed on my brochure, Compassion Crossing, is right now I think it's like 476, 78 articles on different topics. Educate yourself, but for $165 you're certified. So I'm putting in like a small paragraph, go here, and I'm putting this in chat. You don't have to sell your home. I got kicked off at a Zoom call.
Because you were telling them a cheaper way to go.
Yeah, because I was telling them, like, here's this.
Sales.
Yeah, but it's like, are you that insecure about what you're doing? And I wasn't dissing their 2,997. I was saying, if you feel there's no other way,
Yeah.
here's a way for $165, and it's not to me.
Yeah.
I don't get any of that money.
Yeah.
Like, it's not a referral link. It's nothing.
Oh, they didn't want you cutting into their profit.
No, but I was interesting that you watched that too.
Yes, I saw it and I was watching it and my husband's looking at me, he's like, it just about the price thing is when he's like, I'm like, yeah, I already know. It's not happening.
Oh my.